Assalamualaikum. My name is Dr. Syed Bilal Bukhari and I am Senior Registrar Orthopedic Surgery. And today I am going to give you a lecture on infections in orthopedic surgery. The first part of my lecture would be about osteomyelitis. This is an acute or chronic inflammatory process of bone marrow, and its structure secondary to infections with microorganisms. And we can classify your osteomyelitis according to its duration. It may be acute, subacute, or chronic, and it may be classified according to its mechanism. Like it can be hematogenous, it can spread from some distant infection. Patient may have a tonsillitis or a pneumonia, and the pathological organism may travel from that distant organ through blood into the bones. And osteomyelitis can be exogenous. It may be due to some open fractures, which is the most common type of exogenous osteomyelitis, and may be due to injections. And osteomyelitis can also be classified according to host response. It may be pyogenic or granulomatous. So acute osteomyelitis, as far as its epidemiology is concerned, it is more common in infants and children, and males are predominantly more affected. And the important thing is that its location is in the metaphysis of the long bones, and it is more common in societies, in communities who have unhygienic surroundings and are malnourished. And as you can see, as I was referring to it, that the most common site of acute osteomyelitis is metaphysis of long bones. And the reason of this is seen in this picture. You can see that there are sharp hairpin turns in metaphyseal capillaries. And in this region, the blood flow becomes slow. And the pathological organism has time to come out of these hairpin loops. And as you can see, these are hairpin loops. The blood flows in these directions, and the pathological organism, whenever the blood becomes slow, the pathological organism has time to come out of the blood vessels and rest in the bone marrow, and here infection starts. And the pathogenesis is the first thing is invasion of bacteria into the cancellous bone, and whenever there is any insult in the body, any part of the body, it leads to inflammation. And bacteria invasion is an inflammation. It will lead to inflammation and edema in the bone marrow spaces. But unlike the other parts of the body, bone is a tight compartment. Whenever there is some inflammation and swelling in any part of the bone, there is no space allowed by the bone to expand that swelling, expand that tissue. So ultimately, what will happen is that it will lead to compression of blood vessels, and there will be severe compromise of the blood supply of the bone, and will lead to ischemia and necrosis of the bone. Uh, Along with that necrosis of the bone, which is a late sequelae of the acute osteomyelitis, it's the end stage sequelae of the osteomyelitis. Along with that, there is pus formation inside the bone, and that pus can travel from anywhere uh, into the. It can travel into the surrounding joint, as it is the infection is most commonly uh, happen in metaphyseal region of the long bones. So this pus can travel into the joint. It can leak into the joint and cause septic arthritis. And this pus can erode the cortex, erode the periosteum, come into the soft tissues and become abscess in soft tissues. Here is the what I was telling you about. That it is in metaphyseal region. This infection starts in metaphyseal region. It leads to inflammation and swelling, blood vessels compromise, ischemia, necrosis of the bone, and pus formation. And this pus formation can erode the physis. This is metaphyseal region, this is physis, and this is epiphyseal region. So this pus can erode this physis of that young child. It can come out into the soft tissues, and it can erode into the joint, and it can cause septic arthritis there. So acute osteomyelitis begins in medullary cavity, it extends and spreads to cortical bone and eventually reaches the periosteum. And as far as etiological agents are concerned, in patients of less than 1 year of age, the most common organisms are Staph aureus and E. coli. In patients of from 1 year to 16 years, the organisms are Staph aureus, Streptococcus pyogenes, and H. influenza. After 16 years, Staph aureus, Streptococcus epidermis, and gram-negative bacteria are the causative organisms. As far as clinical presentations is concerned, pain is the most common and the earliest presentation of osteomyelitis. As I have already told you, the acute osteomyelitis is most common in young children. The patient, that child presents as inability to bear weight, inability to put weight on that limb, which is also called pseudoparalysis. So and pain is the prime most and first presentation of acute osteomyelitis along with fever, which is usually high grade. As far as local redness, swelling, warmth and edema is concerned, these changes, as you can see and well appreciate in pathogenesis, that, that by the time pus reaches in the soft tissue and become a soft tissue abscess, the damage to the bone has already occurred. So by the time local redness, swelling, tenderness, warmth and edema develops and become apparent over the skin, the damage to the bone has already occurred. So the pain and fever. Whenever a child presents to you with pain and high grade fever and pain in the limb, any limb, and refusal to use that limb, your first differential diagnosis should be acute osteomyelitis or acute septic arthritis, and that patient must be admitted in hospital and should be evaluated and should be started IV antibiotics. As far as laboratory findings are concerned, the usually patient presents to you with elevated TLC, elevated ESR, elevated CRP, and blood cultures is positive in half of the cases, not all the cases. X-ray findings. You see, as I have already told you, that pathogenesis starts with just inflammation, and patient presents to you with pain and high-grade fever. And it takes from 10 to 21 days for bony changes to become visible on conventional X-ray. So the diagnosis is mostly clinical, and you start microbiological diagnosis on bone aspiration, blood cultures, and cultures from other septic foci. Antibiotics therapy is usually high dose parenteral IV antibiotics are started, and as the most common organisms are gram positive uh, bacteria, or based on the gram strength of the aspirate, empirical therapy can be started. And whenever the culture and sensitivity results come, you can change the antibiotic if necessary. And when patient becomes stable, you can change from IV antibiotics, parenteral antibiotics to oral antibiotics, and a period of 6 weeks should be given a full dose of antibiotics. And the most common and most sensitive indicator to see or monitor the response of the treatment is C-reactive proteins. The complications are bone abscess, septic arthritis, septicemia, fracture, growth arrest, overlying soft tissue cellulitis, and chronic infection. Now, the second topic of my lecture is subacute osteomyelitis. So you can see it has an insidious onset. The onset of acute osteomyelitis was acute, and it has an insidious onset with mild symptoms and lack of systemic reaction. There would be no fever or no lethargy, malaise, etc. And its relative mildness is due to organism being less virulent or patient more resistant. So, and the most common sites are distal femur, proximal, and distal tibia. Organisms involved are most commonly Staphylococcus aureus, Streptococcus, Pseudomonas, H. influenza, Pseudomonas aeruginosa in IV drug abusers, and Salmonella with patients of sickle cell anemia. The clinical presentation is pain, which is usually there for weeks and months, maybe years, and limping, mild swelling, and localized tenderness. And due to that persistent pain, patients usually develop localized muscle wasting. And body temperature is usually normal. There is no fever. It has an insidious onset. It lacks the systemic response. The features of systemic response like fever. So on X-rays, there is a circumscribed, round, oval cavity containing pus and pieces of dead bone, which are called sequestra, surrounded by sclerosis. Most common site, as I have already told you, is tibial and femoral metaphyseal regions, and it may occur in cuboid bones. Metaphyseal lesions usually cause no or little periosteal reaction. Diaphyseal lesions may be associated with periosteal reaction. Here you can see a classical picture of subacute osteomyelitis, where you can see a well circumscribed rounded lesion in proximal tibia, and it is surrounded by a rim of sclerosis with a central radiolucent lesion surrounded by radiopaque rim. And the X-ray findings may resemble osteosteoma or some malignant bone tumors. So therefore, the most important thing for this is that along with baseline investigations and baseline inflammatory markers like TLC, ESR, CRP, we should go for an MRI of that bone and biopsy of the lesion. And the fluid aspirate and culture should be sent for culture sensitivity. Patient can be treated conservatively with immobilization and antibiotics for 6 weeks, but most commonly patient needs a surgical debridement, surgical removal of the dead tissue and pus with an open biopsy, plus curettage of the lesion. As far as chronic osteomyelitis is concerned, it is a severe, persistent, and incapacitating infection of the bone and bone marrow. Organisms usually involved, uh, you see, it's a persistent and continuous infection. So by the time you see a chronic osteomyelitis, it is usually a mixed infection. And as Staph aureus is the most common organism being involved in acute osteomyelitis or in the subacute osteomyelitis, so it is also the most common organism in chronic osteomyelitis. The other organisms may be Staphylococcus pyogenes, E. coli pseudomonas, Staph epidermis, and this Staphylococcus epidermis is the most common bacteria in surgical implant, the chronic osteomyelitis caused by surgical implants. The most common organism in animal bites is Pasteurella, and the most common organism in human bites is Echinella corodennis. The etiology is inadequately treated acute osteomyelitis. If a child or any other patient develops acute osteomyelitis and it is not treated aggressively and thoroughly, it will convert into chronic osteomyelitis. And the other most common cause is open fractures. There are few features of chronic osteomyelitis which are hallmark of this incapacitating and uh, very bad disease. And one of the most common features, I will tell you, you must remember four cardinal things, four important things about chronic osteomyelitis to diagnose it and to remember it. And these are four things you should remember as far as your exam is concerned. And one of them is discharging sinus. There will be a discharging sinus, either healed or active, but there will be a discharging sinus in chronic osteomyelitis most of the time. And along with that sinus, you will find some pain, redness, and tenderness in localized region. So, inadequate treatment of acute osteomyelitis. This is the pathogenesis of this chronic osteomyelitis. You can see that inadequate treatment of acute osteomyelitis, a foreign implant or an open fracture, leads to an inflammatory process which continues with time together with persistent infection. And that persistent infection in the bone leads to increase in intramedullary pressure again and again due to inflammatory exudate pus slipping from in the slip. And that pus inflammatory exudate strips the periosteum, leads to vascular thrombosis, vascular compromise, ischemia, necrosis of the bone, and that dead necrotic bone is called sequestrum. And this sequestrum formation, if the surrounding periosteum is intact, this sequestrum formation will be responded by the body with activation of periosteum, and that periosteum uh, lays down a rim of newly forming bone, and that new bone formation which occurs around the sequestrum is called involucrum. So, as far as chronic osteomyelitis is concerned, you see, I have told you that there are four things which you should always remember. The first one was discharging sinus. Now, the second thing is sequestrum. Third is involucrum, and the fourth thing is sinus formation, which is also called cloaca. As you can see, multiple openings appear in this involucrum, this newly formed bone, and through which exudates and debris from the sequestrum pass through the discharging sinuses. Here you can well appreciate that this white piece of bone is sequestrum. This is dead, necrotic, radiopaque piece of bone uh, present in the center of the bone. And around this piece of bone, there is newly formed bone let down from periosteum. This central piece is sequestrum, and newly formed bone around the sequestrum is called involucrum. And if an opening uh, is present in this involucrum, that opening will be called cloaca, and that cloaca will lead its way through the discharging sinus in soft tissues and skin to the exterior. Here you can also appreciate this white piece of bone is sequestrum. Here it is, sequestrum, involucrum, cloaca, and discharging sinus. Sequestrum, involucrum, cloaca, and discharging sinus. So these are four things you must always remember about chronic osteomyelitis: sequestrum, involucrum, cloaca, and discharging sinus. The involucrum is a sheath of reactive new immature superiosteal bone that forms around the sequestrum, effectively sealing it off the bloodstream just like a wall of abscess. And the management is improve the nutrition, take rest, take antibiotics, and surgical debridement of sequestrum. That sequestrum must be removed to allow the bone to heal. Surgical treatment is debridement to remove all the infected tissue that devitalize bone, sequestrum, and sinus tract. Complications of chronic osteomyelitis are pathological fractures, deformity, and shortening or even lengthening of the bones.